Okay, Alison, I think we're good to start. All right, hello everyone. I'm Dr. Colleen McFall. I'm one of the cardiac anesthesiologists here at the University of Ottawa Heart Institute. Welcome to today's Heart Institute Grand Rounds. We are truly honored today to welcome Dr. Burkhard Mackensen from the University of Washington, who flew here all the way from Seattle just last night. For this hybrid event, we have audience members in person in the auditorium at the University of Ottawa Heart Institute and also audience joining online. For those in the room, any questions following the presentation will be posed using the standing microphone over there to your left. For those joining us virtually, please submit your questions using the Q&A feature. We will also accept live questions at the end. Use the hand up feature. You will be asked to unmute by the moderator, which is myself. You can use the chat feature if you are experiencing any technical difficulties. Today's lecture is titled Image-Guided Therapy, an Emerging Paradigm. Dr. Burkhard Mackensen is the Allan J. Treuer Endowed Professor of Anesthesiology and Chair of the University of Washington Department of Anesthesiology and Pain Medicine in Seattle, Washington. He also serves as the Director of Interventional Echocardiography at the UW Medicine Heart Institute. Dr. Mackensen is a practicing cardiothoracic anesthesiologist and a key member of the UW Structural Heart Valve team. He's an internationally recognized expert in perioperative and interventional echocardiography and is intimately involved in multidisciplinary efforts that aim to advance minimally invasive transcatheter cardiovascular care. He has given numerous national and international lectures on the role of 2D and 3D TEE in interventional structural heart disease and surgical decision-making. He has published over 140 peer-reviewed journal articles and has authored more than 20 book chapters. As an interventional echocardiographer, Dr. Mackensen has actively provided procedural image guidance in more than 50 live cases transmitted to national and international audiences. Dr. Mackensen is a fellow of the American Society of Echocardiography, chair of the ASE's state-of-the-art echocardiography meeting, and the immediate past chair of the ASE's Council on Perioperative Echocardiography. He also represents the Society of Cardiovascular Anesthesiologists at the Echocardiography Board of the Intersocietal Accreditation Commission. And as part of that board, he helped create the opportunity for perioperative echocardiography services to be accredited by the IAC. It's truly an honor to have him here, so let's welcome him.
Well, thank you so much. It's fantastic to be here. It's early morning for me, as you can imagine, coming from the West Coast. And it's a true pleasure to be here and also see Colleen, who was a fellow with us in 2017 and 18 in Seattle. So I hope I'm okay standing over here and everyone can see me all right. Thanks for coming in person. It is fantastic to see a room full of people interested in the topic. I do on occasion do some research with Philips, but otherwise have no disclosures. In terms of the objectives, I'll skip this more or less, but I think what I really truly want to do today is just for you to sit back, enjoy. There's no hard science here, but there's some history and there are lots of images. And just appreciate the fact that it takes an effort to produce these images. And then once you acquire them, understand them, present them in a way that anyone can really understand the images, interpret them together with the imager, and then act upon these images. And that's truly what I'm trying to accomplish today. So if we think about what has happened over time, this builds up in not in the sequence that I wanted, but let's see here. We started with open heart valve replacements, and the fellows in the room, these are ball and cage valves that are no longer actually seen in patients. I think there's one patient in California who still lives with that valve, but it may have been explanted by now. And we've moved on to either on and off cardiopulmonary bypass, minimal invasive surgeries for sure, and then percutaneous approaches. Along with that, we've seen a huge exponential growth in imaging needed to help the cardiac surgeons for the minimal invasive surgery, obviously also open heart, but then also transitioning to structural heart interventions. I briefly introduced the main players, which for this talk is going to be the mitral valve ultimately, but there are 4 valves, as we know, and I often think of it like a classical quartet. I used to play the violin myself, and I've listened to this quartet, the Melos quartet, quite a few times. So if you think of the 4 valves and you look at them en face, meaning really look into them with the aortic from the aortic side of things, the mitral from the left atrium as if you're standing like a surgeon on the left side of the patient, and then an en face view for the tricuspid, which could be the violoncello, and then perhaps the pulmonic valve I assigned the viola. Those of you who are aortic surgeons in the audience who are here, don't be offended if we not talk about the aortic valve, though it is often thought to be the first violin. I think it makes sense for the TAVR or TAVI revolution, however you call it, that the aortic valve was first for the structural heart procedures. Now I've flipped the same valves. Now we have a different perspective. Again, an important piece. When you have a 3D image, you need to present it and understand from where you're looking so that you know what's up and down and what's right and left. And again, the pulmonic valve as seen from the RVOT on the right-hand side. Now, a few years ago, we got together first with a task force and then with more of a developing interest group to really claim this new growing subspecialty of echocardiography called interventional echocardiography. And by now, this is actually an ASE Council, American Society of Echocardiography, recognizes it as a subspecialty that has enough members represented that now it has a seat on the board of the ASE as a council. And essentially what this is a first universal recognition of the central role of the imager in structural heart interventions. And this could be a cardiologist, this could be an anesthesiologist, to help and work together with the interventional cardiologists. We are crucial behind the technical success. Without seeing, you can't place clips or you can't replace a valve. You have to know where you're going, and you have to be also do it safely. There's certainly a unique and recognized knowledge set that allows us to not just acquire the images, but again, as I said before, also interpret them in a way that they're understood. Here are just a few aspects of what this entails. I think a key is at the very bottom, which is physiology can be observed in real time and can be altered, and we see immediately what's happening in front of our eyes. It is certainly an image-guided approach, so we really take often the lead role, which is a little different to perioperative echo, where we often present the findings and then perhaps have a discussion with the surgeon about what we see. Ultimately, the decision-making often is truly in the hands of the surgeon. Here in the interventional space, it is more back and forth and a continuous communication. Now, how this looks like, you see here, hold on, let me go back. You see here a little bit, you have hands-on, you have an echo image that develops along with fluoroscopy. I'll play right now, so I'm gonna just move on in the interest of time, but this is what we want to prevent. This is going in the wrong direction. It's actually going right straight into the left atrial appendage. This is a mitral clip in the early days, which luckily we caught ahead of time so that there was no injury to the heart chamber, in this case, the left atrium. Importantly, in 2023, we came out with these screening guidelines, which really was a huge effort. It's one of the longest papers I've ever been involved with, 75 or so pages. So it's not a straight read through, but there are sections for each structure of the heart, including the 4 heart valves. There's no device, so it's device agnostic. It doesn't help you to guide the procedure, but really it helps to screen. And in fact, this one here is the effort then to bring it all together. And I'll come to the screening echo paper in a moment, But this one was really to focus on how can we best set expectations for people to learn. And we had to again acknowledge the fact that we have cardiologists, we have cardiac anesthesiologists coming all to the same goal of becoming interventional echocardiographer. Here you see for cardiologists, it's the level 1 and 2 up to level 3 with the COCATs and ASE recommendations and how we may get there. And you need certain ingredients that you seem to have all in place to train appropriately for this new subspecialty. And this is involving, again, the expertise to incorporate new devices, to have the environment and the technical understanding on the interventional side, practicing cardiologists and anesthesiologists, and really to be programmatic about this subspecialty. And then if you think about it, in our effort to say, what do you need to stand up a program? You need the learning environment, but you also obviously need the equipment and the facility. Last night, we talked about upgrades and technology that need to keep up with us and we with the technology in order to be at the forefront of this. You need the faculty with the experience and ultimately the heart team that is resembled in this room, be it virtual or in person. Now, here are the two pathways for level 3 training and then the interventional training on the anesthesiology side. We are currently moving to a formal fellowship for this at the University of Washington. So my colleague, Richard Shu, is tasked to not just have a curriculum, but actually set up a programmatic faculty fellowship, how we call it, to be versed in this field. And let me, at this point, just share a few, for those of you who are involved, share a few pearls that I think you may want to take with you and just consider. First of all, we cannot just show up and not know about the patient. We need to also be sure that our workspace, our working triangle is set up. When I first came to the University of Washington, the echo machine was on the opposite side to what I was used to do, because I had to work on changing that around. And now that makes a huge difference. Sometimes if you don't get there in the morning, the setup may not be quite what you need. There needs to be procedural knowledge on the imager's side. So you need to put hands on the devices to understand what can and cannot be done, because you cannot ask something that is impossible from a technical point of view. Always want to take cues from others in the room. We do have to have backup plans. So what do we do if our initial plan doesn't work? The communication, as I said, is always on. So ideally, you really have no barrier to communication, that you always feel like entitled, appropriately able to speak up when you need to. I also think it's important to, at some point, based on experience, to lean in and be assertive, because ultimately we need this fiduciary certainty, or need to be convinced that something is the way we see it. There's always a need for multiple imaging planes and modalities, so don't be satisfied with just one view. It may be the opposite of what you think. You need to think ahead in terms of the procedural flow. And I think ultimately for the fellows, as well as for us as faculty, always need to strive for excellence. I'm convinced you can always improve the image. There's no question at any point in time. Its intent, its contact of the Echo Pro is, if you do a transthoracic echo, you won't rest until you have a window. Same is actually true for the TE probe as well. So here's, you always need to help your colleague, help them out if they fail the approach. Just quickly wanted to go over this history again. I don't have time to do everything here, but take the fact that now more than 200,000 patients worldwide have been treated with edge-to-edge repair using the MitraClip. Many patients have been in clinical trials. A key point is 2007. I was still at Duke. The first TE probe that was 3D capable came out. And I kind of was in the right place at the right time. I asked the division chief at the time if I could spend a little extra time on this. And he recommended, so Joe Matthew, he recommended for me to do so. And he also said this will revolutionize what we do in the operating. Now, at that point, it wasn't as clear yet that in 2010, we would be fully part of the Everest trials at the time. And now fast forward, we have not just one, but several devices for edge-to-edge repair, not just on the mitral, but also tricuspid valve now. It's really been an enormous development. With that is the recognition. It's important that we couldn't have done this just with the technology on the interventional side. Imaging felt so much better. So here I brought with me the original 3DTE at Duke. I wasn't at Duke in '84, but I came to Duke the first time in '97 to 2000, left for 4 years and then came back in 2004. So Joe Kislow, who's here in the left in the image in the middle, he's still alive. He was one of the first AC presidents, a fantastic mentor and guy, really at the forefront of developing this. And this was obviously not a patient who took this, but yeah, here's the first image even of this mitral valve that you see here. The technology in the back rooms was a little different to what we see now. It's just important to realize that development. Now, this is truly my first 3D image, and I'm not making this up. This actually went into echo rounds into anesthesia, which was not a straightforward slam dunk. It was actually a difficult discussion about the surgical case behind this. But this is a flipped around left ventricle. You are in the apex of the heart. You don't need 3D glasses. And we couldn't believe how clear SAM, systolic anterior motion of the mitral valve is illustrated, where the LVOT essentially is here, and this leaflet during systole just closes that off. You know, a picture worth 1,000 words. Again, one of the first 3D images was 24 hertz that I took at Duke in 2007. Now, fast forward, the mitral clip, I talked about it. This is a landmark study that is the CORE-UP trial, presenting the fact that the mitral clip plus goal-directed medical therapy has a huge impact on hospitalizations and mortality. And this was initially in the functional MR, secondary MR. If we compare for a moment, acknowledging the surgical approach that really is what the edge-to-edge repair mimics, is the Alfieri stitch. At some point, I had the honor to meet Dr. Alfieri actually in Suda, Montana, of all places, at the Rocky Heart Valve Symposium. And essentially, the differences are laid out here. And I'm, again, not going over all the points here, but the key aspect of difference is the surgeon has to place an Alfieri stitch into the flaccid heart, hope that it's in the right place and that it does what it's supposed to do. If it's an adjunct to an annuloplasty, nowadays no surgeon would do just an Alfieri stitch. And the mitral clip, or the edge-to-edge repair, better to say, is dynamic. So we can place the clip, can look at the effect, yes, still on the relatively stiff delivery system, but then we can move it and we can place it somewhere else, or we can add. So there's a lot of more ability to look at this before we actually release it. So those are the key differences here. Now, I'm going to quickly go through a comprehensive approach to not just what I have on this slide, the pre-procedural imaging, but also through a mitral clip procedure, just to go over the key aspects. Again, it's important to know what we're looking at baseline. So we have to be comprehensive. And now I'm coming to this paper, which ironically I talked about earlier, which is the screening TE workflow, where we have an approach to all of the structures in the heart. Again, it's freely available on the web through the American Society of Echo Guidelines webpage. And I signed responsible for the mitral portion, so I brought a few images from that. This is essentially the Carpentier classification, where you have normal leaflet motion on the left, all the way to excess leaflet motion for Carpentier 2, and then down to restrictive on the right-hand side, again, resembling in our imaging flow When you look at primary degenerative MR on the left, echo images I took at some point, you see the dynamic, you see the bileaflet prolapse, you see the contractility of that ventricle, and that's a very different, stark difference to a functional MR scenario where all the leaflets are tethered down, all cords are in full tension, and there's no ability to form a meaningful coaptation plan. Take that to interpretive 3DT. When we do model these valves, we can learn a lot about the movement or a lack thereof of the annulus, the speed by which the annulus moves, and things like that. So this is a TomTech quantitative assessment on the left-hand side. Again, a functional case on the right-hand side, where the heart is barely contracting. If we know our skillful, we go systematically through the mitral valve using biplane as well as volumetric 3D imaging, as you see it in the middle, and we interrogate with and without color in this biplane mode. These are just comprehensive aspects of quantifying MR, which again is essential so that we know how was it at baseline and how was it at the end of the procedure. Again, not spending too much time on this. I want to go here for a moment and just show how in a live scenario, this is a live case I participated in Leipzig at, this was 23. I'm going again this May. We're doing 3 days, just live cases, both from the operating room as well as from the interventional suite. And I can really recommend that meeting. You can join virtually or in person with Sheet 11. Basically up to 8 cases every day for 3 days. A lot to learn. And they do have the camera on my hands, so everything is shown. Also the touch screen of the machine and how I get to these images. So if I go and have a 3D image like this, I can use the multi-view or multi-planar live presentation. And if I go and actually add color, as on the next one, then we can really plan a procedure. So here I'm illustrating a MR jet that's going from posterior to anterior. It's kind of washing up anteriorly. And then I'm using the multi-view option. So I'm going into multi-view right there. And then this will turn into a different viewpoint. Now we have the 3D volume in the right corner, but we have 3 perpendicular axes, the short axis and 2 perpendicular long axis on top. This will be a commercial view, and this will be a long axis view. If you already appreciate the jet, you say, yeah, I got it. There's an anteriorly directed mitral valve, jet, that's regurgitation. But we need to find out where's the maximum of that jet. What's the orientation? How should we approach this valve? And so what I'm doing here is I'm going really into minute considerations by turning these planes that are now linked and locked to each other. And I can essentially move this around so that ultimately, if I fast forward this a little bit, we actually get to a point that I'm smack in the middle of this jet. And then I can start seeing that the perpendicularity perhaps of this jet is not 12 o'clock, 6 o'clock, maybe it's a little bit off. And it may inform how we place an edge-to-edge repair. So I hope you at least take that from this real-time imaging. The quality of the 2D images is getting so good that we can essentially do entire procedures in this multiplanar approach nowadays, which also helps to prevent the probe going in and out of the patient too many times. Now, this is an interesting display of 3D on the left-hand side. I don't think it's easy to understand what's going on in this mitral valve. So what I do at times, and I hope this will play, it's just a frozen image. So I just freeze in systole. Then I have the MR jet. I do have a different display here with glass view, it's called. And I can now flip this image in front of my eyes. That's just like a 1-year-old who's just exploring something. And I start to understand what's going on. So this jet comes out of the anterolateral commissure and it goes all the way up. And I think it's displayed here as well. This place as well. So again, this now you see where it comes from. And if I do this on the right-hand side, And I changed the transparency. I can even see the forming of the pizza in the LV, and as it goes across, now I play it. Now I start understanding what's going on. In the moving image, it wasn't clear. So again, at times we need to do that. The procedural planning can go as far as really aligning the perpendicularity. This is a case of a commercial issue in this valve. You see the prolapse indicated by the yellow arrow. That's a P1 prolapse. And so we can actually pre-plan the directionality, the orientation of the edge-to-edge repair, how far we have to cross over to really do an edge-to-edge repair and get not side bite or just a little bit of one of the two leaflets. Again, important. We have to understand the technology. This is just one of the technologies. It's the mitral clip. We need to know the dimensionality, understand which tool to use when, things of that nature are important. This led me to work with one of my colleagues for this book, actually. Initially, this was on the left-hand side, a paper where we used the generation 4 mitral clip in 150 plus patients and had a very thorough assessment of the results that we got in comparison to older technology. And then on the right-hand side in this book, which is also freely available through the FSCAI, where I'm also a fellow, and that gives a little bit of an indication of which clip to use for which scenario. Again, it gets quite granular if you think about it. This leads me to consider who should be treated where, and I think similar to surgical centers of excellence, there is that in interventional or structural heart disease. And you know, there may be the initial inclusion criteria for any trial that are then recommended, for instance, by the FDA or similar bodies, up to suitable and then more expanded indications. And then all the way to the right, you may have the most challenging or even unsuitable case scenarios, but we've clearly pushed hard into this more extreme aspect of it. Now, again, I talked about before, this needs to be a safe procedure. When I showed that left atrial appendage, this transeptal puncture business is actually not trivial. At first, people think, oh yeah, that's just going transeptal. I just have to have a couple of views. This can be a tricky part of the procedure. And my interventional cardiologist, Jamie McCabe, will always say, this is one of the parts of the procedure that separates the excellent imager from the one who's struggling to actually show him where he's at. At times, it's very hard to find the tent. Maybe there's not much of a tent, or maybe they're much further down than the T. You probably need to look at the fluoroscopy screen in order to get there. 3D can be of great help, and I think the perspective we get is phenomenal. But again, you have to know how to interpret, and your interventional cardiologist has to buy in. But here are just some standard views using a bicable and then producing an inverted 4-chamber view or an aortic valve short axis view with bicable, again, using biplane technology. But I brought this from some earlier time where we actually really in the cadaveric heart model put together fluoroscopy TE and then the actual haptic experience of the interventional cardiologist. And this was phenomenal for me to actually have my hands on myself on trying to do a transeptal and get that feel for that rich like surface on the right side of the atrium of the intra-atrial septum. Really a cool opportunity to put it all together, almost like a simulation. The flaccid heart that was actually filled with saline. Now, here are some 3D images, again, showing the tenting right there. That certainly helps to put things in perspective. And then we can also crop into the 3D to measure the height that's needed in order to be at the right spot and come across to the mitral valve, as you see here in these illustrations. I'm going to go forward with this and just show, again, 3D can be used in live fashion to guide the mitral clip down, in this case, to the mitral valve. Again, a stepwise approach. And here's just some illustrations on how this actually looks like. Again, this is a big device that's coming across. So you want to be sure that you're not coming in and out of the pericardium. It's essentially going through Waterton's groove. where you then, if you pull out the device at the end, you could have significant cardiac tamponade. So again, it's important to be in the right spot. Ultimately, we're guiding the clip across the valve. On the right-hand side, I've turned down the gain so you can see the clip orientation in order to get to the right approach. Now there's posterior grippers and anterior grippers. There's unilateral gripping opportunity. It's called gripper actuation, but essentially what this next slide shows you is that we already caught one of the leaflets in this approach for the edge-to-edge repair. And the second one is still falling onto the clip arm. And then eventually we bring that gripper down as well. We see it on top of the leaflet, essentially starting to sandwich. And then the clip can be brought together for a true edge-to-edge repair. And then it may look like this, and we may actually almost distort the valve a little bit like you see it here. We have to be careful, again, acknowledging the natural way the mitral valve is shaped and formed and not distorting anatomy too much with this approach. This is just an illustration on how you can use, again, a multiplanar approach to interrogate the insertion of the leaflets. Again, we don't want to leave a clip behind that may not stay there and be only attached to one leaflet, because then we really got a problem. So again, multiplanar views are really helpful to appreciate all that. At the end of the procedure, we need to make sure we have done what we came here for, that the MR severity is what it's supposed to be, and that there's no more additional work to do, that we didn't create a gradient across the mitral valve and things of that nature. In order to assess mitral regurgitation at the end, we worked together with the group at Houston, and this is Eleonora Avinati, who came actually to visit in Seattle, I think about the time that Feline was there, and helped to go through our research data sets. And we came out with a recommendation not only to help approach the quantification, but talking about a vena contracta area rather than just the width, as you see it illustrated here. For the learners in the room, if you have functional MR, it's often an eccentric shaped footprint of MR. If you just measure the width of that jet, it may be underestimating the severity. But if you appreciate the full footprint, as I often call it, it's that vena contracta area. And in this case, it's 1.34, so it's pretty large, certainly severe MR. So we use this approach in a larger data set, retrospectively appreciating the vena contracta area at baseline and then post-clip, and found that a cutoff that we recommended at the time, at least, was about 0.25 centimeters squared. So if we had more than that we would leave behind, we would strive to add another clip and reduce the MR further. Otherwise, hospitalization within a month or potentially having to come back for a second procedure was a more likely thing to happen. So let's talk about briefly what not to do. I talked about the pearls of what to do. There are also some things we shouldn't be doing. I don't know how well you see this, but this is close to Seattle in Alpental. And at times I do go backcountry skiing. And here I saw these snowshoers going exactly up where all the skiers are shooting down in the backcountry. So quite dangerous. If you look, it says keep right. They're certainly not doing that. So that you have to follow some instructions. There's actually instructions for use for the mitral clip or other structural heart devices, and we need to follow those. I also think it's important to pause at times, as I showed, freeze an image and not rush to conclusion. You cannot act in isolation. Again, this is more of a team sport. I don't take shortcuts. At times it's hard. You have to say, well, wait a moment, I'm going to have to regroup, find a better pro position, maybe bring up my 3D image in a different way. Can't get distracted. Really, we're on with the imaging we are focused on. Can't leave before the end of the procedure. Often I found, even last week, I found that due to a little bit too anterior approach, we had injured the intratracheal septum quite a bit. It was much more wide open than thought, and it actually bidirectional shunt. And then we had to close it. The first closure was too small of a device. We had to upgrade the device. So, you know, it's only done when it's really done. But don't pretend you know something that you really don't. So you can't make up stuff. You have to be honest in this. But also, I recommend to try new things, not when it really matters. There's always opportunity to have patient data set that you could play with it offline. Hope we get to do that today with the fellows, and we can talk about what we are able to actually do, not in the life situation. Never underestimate the risk of what we do. We've treated at the University of Washington many patients that are under compassionate use. We've treated about 180 patients now with the TriClip for the tricuspid valve, and it's a risky business, but these patients often don't have another place to go, or they have no other alternative therapies. So we need to appreciate the opportunity to treat them. We're not ever invincible, and then it's also important to celebrate wins. If you get something done that maybe 5 years ago, maybe a day ago, we thought was going to be impossible. Now let's do a couple of cases here. So here's an anterior leaflet prolapse treated with the MitraClip system. Again, I spare you the details of this history. Suffice it to say, certainly a pre-surgical patient who was not deemed to be ideal for a surgical approach at this point. Massive MR, anterior leaflet prolapse. On the right-hand side, you see the ventricular perspective. Again, I'm talking about this huge vena contracta area. Here we are doing a multiplanar view, again, estimating the baseline MR, more quantification, including systolic flow reversal in both the right upper and left upper pulmonary veins, with even a PISA that was 0.46. So clearly a lot of MR. Here's the first clip, and we are in place pretty much down the middle of the valve, if you will, creating these two ostia. And yes, we do have some remaining MR. So now what do? We split the clip, we split the MR a little bit in the middle. Not surprisingly, given how big it was at the beginning. But if you pay attention, you flip the image on the right-hand side where I have the error, it looks like this ostium is decisively bigger than on this lateral side. So we actually looked more closely at this medial situation. And if you then look at the 3D without the color, you find that there's a remaining A2 prolapse over here that doesn't seem to be appearing on the left-hand side, meaning on the lateral aspect. So this was the bigger jet. We added a smaller clip, in this case an NT, more narrow. We didn't want to take too much real estate of the valve, not to create MS, mitral stenosis. And here you see the approach for the second clip, really cleaning up this pathology, really going after the pathology. And then here you see the final result. These are very, very much trivial MR jets. If you look from below now, you barely see anything here. You see that initial lateral one maybe. This is actually medial. This is all that's remaining. But we normalize pulmonary venous flow in a very anatomic or pathologic focused approach. Here's the before and after. So in summary, again, using the right tool at the right moment, acknowledging pathology and treating exactly the pathology in front of you. Another quick case, more of a left ventricular failure patient, dilated cardiomyopathy, poor EF, part of the COAP trial, certainly in terms of inclusion criteria. This patient was not actually in the trial, but would have potentially gotten into. Maybe the EF was actually too low for that trial. And I bring these images just to illustrate that 3D at times can really educate us about what does it mean to have functional or secondary MR. I talked before about tethering. All strings are attached. See how much pull there is on the leaflets, and they have no chance to come up and go out in a meaningful way. This is an anterior and posteriorly oriented 3D image. In this particular patient, the short axis from the transgastric position is beautiful, and also illustrating the MR as you see it on the left with and without color. And then the 3D from transgastric also gives me a good overview. And then if we do a biplane on that short axis, we actually see a long axis view on the right-hand side, which usually we wouldn't expect here. But again, this illustrates, like, without any surprise, that tethering of that mitral valve posterior leaflet that is all the way coming down vertically. Again, not any chance for coaptation. So this patient was carefully titrated by our cardiologists for optimizing heart failure, goal-directed medical therapy, still huge volume overload, presented to us to see if we could maybe help this patient. Here's the quick procedural grasping and the grippers down. This patient again had great imaging, especially from the transgastric point of view. Again, short axis and long axis. You really see even the grippers on top of the leaflet here, I think, quite well, especially down here for the anterior leaflet. And then this is interesting because you actually see how we are closing the clip in real time with the color on. At first, there's a lot of MR, and as the clip is being closed, you see how little MR there is on the right-hand side. That's essentially now the clip is closed. And the loop goes back to the beginning of this severe MR. Again, that's what I call this dynamic monitoring of the effect of what we do. Looking at insertion, making sure we have what we need, that both leaflets are securely in there before we deploy. And here's the final deployment. Now you have the clip in the center of the valve, huge reduction of MR, two orifice figure 8 configuration, similar to the Alfieri stitch A2 to P2. And amazingly, this patient did so well, actually lost a lot of volume. She was thrilled with her results and has not had to take diuretics anymore, which was really phenomenal to see despite that low ejection fraction. Here are a few options for you to pick the right color of what you like. And this is actually not just a joke. It seems to be that everyone may have a different ability to see 3D. And from a physics point of view, apparently the green coloration is the best to appreciate the 3D without us having 3D glasses in front of ourselves. So I'm looking at time. We can go maybe a little bit further, but I can stop for questions at any point. Just to not describe this as too rosy of a perspective at times. This is what you see when you are in the imaging position. You have a noisy environment. You have surgeons and interventional cardiologists talking a lot. You need to cut through that at times. There's certainly, besides the noise, there's the image intensifier and the radiation that we expose to. And it can be quite hard to work with such a big team in this relatively loud environment. This is a paper I brought along, a review from 2018, just to briefly dive into mitral valve and valve therapies, where we've done a lot. This is an overview of what we have to consider when we plan these mitral valve and valve procedures. And one of the key areas is the left ventricular obstruction that can come about because we push that anterior leaflet of the mitral valve towards the LVOT when we bring a mitral valve into the mitral valve position without cutting out the anterior leaflet as the surgeons would do. So there's a few tricks of what we can do to prevent this LV2 obstruction. I'm not going to go into detail for everything, but suffice it to say, we'd have to come up with new approaches to create space in that LVOT. But the one that's currently most on our mind is the sesame procedure at the bottom. We've now just gotten a paper accepted in Neurointervention where we illustrate our first experience in about 70 or so patients doing the sesame procedure, which is a scoring along the midline of the interventricular septum. If we look at the septum here, and this is an alcohol septal ablation, we see alcohol installed right there as well. You can see that there's a lot of improvement on the left-hand side. There's essentially SAM. This was all closed off, whereas here we have the alcohol installed and we have more space in the LVOT. To go further, there's other techniques that were listed on my initial slide, including the lampoon technique, where we're actually cutting into the anterior leaflet of the mitral valve to create space in the open cells of the mitral valve as it comes into the mitral position. And this is the sesame procedure, just from a schematical point of view. I'm guiding the interventional cardiologist into the interventricular septum guide wire comes in and out, gets snared, and then we do electrocautery, essentially cutting into the interventricular septum, and it falls to kind of either side. It creates a trough as if we would have taken out some tissue. And this is an initial publication by the group at Emory, illustrating their experience. Essentially, in the beginning, it was just Emory and our side. They were fortunate enough to be a part of this, essentially looking at an anatomy that you see here, where we have a guide wire that has come through the septum and then gets snared, as I said, and we cut through. Again, going back to exposure, this is very tricky to image, and you're so close to the image intensifier, it's very hard to optimize protection in this space. This is a recent paper, I think from 24, where we, as a group of interventional echocardiographers, got together throughout the country to come up with recommendations for better protection of ourselves and what we need to do and actually bring back to our hospitals so that we have the infrastructure to protect ourselves. Just briefly give you a hint of how a sesame may look like. Here you see this black hollow space, which was created by this myotomy. Now you can imagine that that adds space to the LVOT. We call it a neo-LVOT, and will prevent an outflow tract obstruction if we do it right. You see a CT before at baseline and post sesame. It's this added space on the right-hand side that was created by this myotomy. And just to illustrate, here's a patient who actually recently met with our interventional cardiologist. He's from the East Coast. He flew in to have all this done. He had an annuloplasty with an alfieri stitch by a surgeon next to a mitral clip that was placed later. He still had severe MRs. He had surgical and interventional approaches on the East Coast. Didn't help him. Came to us. He was very sick, balloon pump at first, and we decided to do all of the things. We did a sesame. We cut out the mitral clip and the alfieri stitch, externalized the mitral clip, essentially moving on. Here's an illustration of how that may look like. You essentially destroy the mitral valve apparatus if you get a clip out. We guide it out with this UNO device so that it's shielded out safe. And then you have to be certainly prepared to place a mitral valve in that situation. This again, back to the sesame in this particular patient. So we had a 1 centimeter depth duration of this reversal of the wire. We certainly don't want to go too deep because you can create a shunt between the two ventricles. So you have to be careful not to get too deep. Here you see some of the guiding images. I'll keep it brief, indicating the result of the LVOT enhancement in this particular patient. See it measured out here. So we're adding this sizing, and then we go about removing the mitral clip. There's no mitral valve, so you see a lot of MR in this scenario. And then we brought in this valve, which is essentially encircle M3 valve by Edwards, which encircles the mitral valve apparatus and then places a central circular valve. And here are just procedural images. I think I'm going to stop here illustrating that this got to a great result. And this is just being part of new developments that open up therapies for patients that otherwise have no longer an option, surgical option. This patient was very sick, was in our hospital for 10 days. Recently met, as I said, our interventional cardiologist on the East Coast and asking out for drinks, which was incredible to hear and also to know that someone who had completely given up hope actually got, albeit a very convoluted solution for that. Again, I'm not claiming that this can be done for anyone, and it has to be a team that has a lot of experience. And an interventional cardiologist, in my case, Dr. Jamie McCabe, who really does extraordinary things with his hands as we go through these procedures. Maybe I stop here to allow for questions. Again, hoping that I was able to bring about the dynamics of this field. It's constantly changing. And so we have to be ready and train appropriately. Happy to answer any questions.
Thank you so much for that presentation. If anyone has questions for the live audience, come on up to the podium. And in the interim, there is one question. There's a question so far online from Dr. Burwash. Can you comment on radiation exposure to the interventional echocardiographer and how you mitigate this in your practice?
Yes. So again, I recommend this paper that came out in 24. It's really important. I go, as I said before, I go to other places and do help with life cases. At times, it's atrocious in how little protection there is for the people who do the imaging. And you have to insist on that protection. Ideally, you do have a shield that goes up as high as possible and circles you, but then also a shield that comes from the ceiling, if it can be built in. That's the ideal combination. There's some actually scientific evidence that that protection together is what's really needed. I started at some point with the mechanical engineering at our school to develop a prototype of what I think is ideal. I think we don't have the perfect device out there. There's room for development. The interventional cardiologists now have devices to protect themselves that they can actually essentially do procedures without lead. I don't know if that's available here. And that's just not fair because you don't have to have your lead on your shoulders. But yeah, it's important to have head protection, eye protection, as much distance as possible, which again, you have to be on the TE probe, so it's not easy that way. There's more room for technical developments acknowledging that as well, but there's a lot that can be done. And if you are striving for excellence, you can actually do much less with fluoro and much more with echo, which really cuts down the exposure. Questions?
Yeah, thank you very much for the talk and for the conversation dinner last night. I've got 100 questions, but I'll limit myself to 2. First off, you mentioned the ASC guidelines on training for interventional echocardiography, and you talked about your fellowship program being in development. My first question is, how prescriptive do you think those guidelines are in what an interventional echocardiographer should go through for training, or do you think it's more of a high-level guideline? And maybe if you could speak to the strengths and weaknesses of that guideline in itself as other centers are considering developing these fellowship programs. And then the second question is about edge-to-edge repair and technologies in general. I think one of the strengths of TAVI is that it's a fairly standardized procedure in the deployment of the valves, whereas edge-to-edge repair and some of these other techs that you're using or that we're using rely on high-level expertise in the imager and the interventionalist. Do you think that that limits these technologies as being the dominant technology in the future, or do you think that clip is the way of the world forever? You can speak to that a little bit.
Yeah, both excellent questions. Maybe start with the first one. As far as these guidelines for training and recommendations are concerned, it wasn't easy. I was the only cardiac anesthesiologist of part of that effort, but I would say we struggled with saying, for instance, how many procedures of X, left atrial appendage occlusion or edge-to-edge repair, or how many transeptal punctures should one have guided in order to be proficient, if you will. And that's a hard one. But again, we try to not set the bar too high, but make sure that the key aspects of imaging are at some point acknowledged and done. And to go a little bit further, I now committed in June to spend 3 days with members of the NBE. We are going to set up NBE exam for interventional echocardiography again, which I think over time, if we look back with perioperative echo or other echocardiography exam, once you have expectations set, as well as then set of goals for what a exam and a certification should need, I think then over time that matures and becomes more clearly graspable. With regards to your second question, I do acknowledge that right now, for many sites, the imager or the availability of excellent imagers is a hamstring, or is a kind of limitation. And we need to have more people capable of imaging. Perhaps think about it a little bit more like a tier 1, 2, 3, where there may be procedures that are a little easier to kind of wrap your head around. Often talking to device company representatives, I get the impression that it is often anesthesiologists who, due to the fact that we use so much T perioperatively as cardiac anesthesiologists, at least, have a lot of experience and an easier approach to this space. And so in many private practice settings, actually in the US, we still have a lot of dimensional imaging done by cardiac anesthesiologists as well, especially for mitral clip or Watchman procedures. But over time, I do think this subspecialty is here to stay. Mitral clip itself is not the answer to everything. We certainly, like other sites, have probably placed mitral clips in patients that should have maybe waited for a valve opportunity. I think the field of transcatheter mitral valve is much more behind compared to the aortic, and there's good reasons for that. That's a lecture in and of itself, of why it's so much more complicated. I touched upon a few aspects, but there are other aspects of why that's so difficult. But again, I think there's promising signs on the transcatheter mitral side of things, that hopefully we can have more of an opportunity to consider various of these structural treatments for these patients. Hope that answers the question.
Are there any other questions? Otherwise, I'm cognizant it's 8:30, so ones working in the OR have to go back. I will just remind everyone the schedule. Our cardiology fellows and our cardiac surgery fellows are going to stay for the next 45 minutes to have a session with Dr. Mackensen. And following that, he's going to work with our anesthesia fellows as well. And truly, it was an honor for us to have you. Thank you for making the time to come out to Ottawa to visit us. And that was a wonderful presentation.